Okay, so in the name of God, the most gracious, the most merciful, good afternoon, ladies and gentlemen. I'm so glad to see you all here. I wish this broadcast find you well and good. In the past few decades, the corneal transplant surgery has evolved markedly from simple replacement of the whole corneal tissue or the whole corneal thickness to only transplanting parts or layers of the cornea, like in the LK, demic, basic, and keratoprosthesis. Now, despite all the improvement on those procedures, we as glaucoma specialists, together with our colleagues from the cornea specialist colleagues, we have a big challenge to deal with those cases of glaucoma after keratoplasty. So in the next 1 hour or so, we have Dr. Ali Al-Bishri. Dr. Ali Al-Bishri is a glaucoma consultant at King Khalid Specialist Hospital. Dr. Al-Bishri received his fellowship from KCASH, and he used to be one of the best fellows, and we were glad to have him here with us in the division. Dr. Al-Bishri is going to speak about glaucoma after keratoplasty. So without further ado, please go ahead, Dr. Al-Bishri.
Thank you very much, Dr. Ahoud. Thank you for this kind words and for moderating this session. So I think I have to share my screen first. All right. Clear, right?
Yes, it is clear, Dr. Ali.
Bismillah ar-Rahman ar-Rahim. Right. As you mentioned before, the glaucoma post-keratoplasty is a difficult issue that we are facing on a daily basis, either in the clinic or during our on-call. So we try to cover this subject in this 1 hour. Actually, it's huge and big, and we'll try to illustrate what we can do during this hour. So corneal pathologies and corneal diseases is considered the fourth causing or the leading cause of corneal impairment or corneal blinding disease, and it's actually preventable if you treat it on the acute stage, and if we have an access to the good health facilities. And on the other hand, unfortunately, if you don't treat these cases on a time, on the right time, we have to go for corneal transplantations. And corneal transplantations is not without complications. So graft failure is one of the complications that can happen either by graft rejection or by glaucoma that can happen post these procedures. So glaucoma is a serious complications, as we mentioned, because has high incidence and severe, and it's difficult to diagnose actually. So we'll go through them one by one through these procedures, and we'll conclude by keratoprosthesis. So glaucoma after penetrating keratoplasty. Actually, it is firstly reported by Irvin and Kaufman back in the 1969, where they described the ocular hypertension after penetrating keratoplasty in aphakic patients, where the intraocular pressure reached 40s and above. And if the procedures combined with other ocular surgery like phaco or cataract surgery, whatever, so the pressure reaches 50 and more. So many reports afterwards, have an agreement that the incidence reached 31 in early postoperative period, and maybe more in the late postoperative periods. This is one of the large studies in the Moorfield Eye Hospital. They included more than 1,000 PKP cases, and they found the incidence was 14%. And the corneal dystrophies and keratoconus counted for the lowest risk to develop glaucoma, while the bullous keratopathy and anterior segment trauma, in addition to eye syndrome and corneal perforations, has the high risk to develop glaucoma. Regrafting is doubling the risk or maybe tripling the risk in the early postoperative period. And it reached 71% if the patient has a pre-existing glaucoma. So the pathogenesis behind this is as you may know that the synechial angle closure is the main cause behind glaucoma after penetrating keratoplasty. And this is a report from an Indian paper describing doing UBM and anterior segment OCT. And as you can see, peripheral anterior synechia is developed after penetrating keratoplasty. So synechial angle closure is always the problem after penetrating keratoplasty. And if the patient developed inflammation, as you can see here in this photo, as you can see that the angle is totally closed with the element of membranous reaction and keratic precipitates. So another pathogenesis we can think of is the steroid-induced elevation of IOP and collapse of the irido angle closure, inflammation postoperatively, and iatrogenic injury to the angle, and vitreous prolapse, which can happen if the procedure is combined with the cataract surgery. So other risk factors, again, as we mentioned, combined with other cataract surgery or lens implantations, anterior vitrectomy if it is done at the time of surgery, and any anterior segment, reconstructions or revisions like removal of the IOL or reimplantation, and even keratoplasty itself can cause or exacerbate glaucoma. This is by changing the angle structures or by using topical steroids for longer period of time. So again, here the prior glaucoma or pre-existing glaucoma is the strongest risk factors of progression after penetrating keratoplasty. Another factors that contribute to the distortion of the angle, we can mention the tight sutures. If you use your sutures in a tight way, you can create a posterior gap on the posterior cornea, and this gap can induce a retraction of the decimus membrane and can crowding the angle. While if you are using, loose suture in a short fashion, it can preserve the decimus membrane and keep the anterior support tight. So also long sutures play a role in distorting the angle. So why is that? Because these long sutures can compress more tissues and cause more crowding of the angle. So if this is the normal anatomy of the eye, it's going to be like that. If it is, if you use long sutures and tight enough to compress the wound, and also it can induce shallowness of the anterior chamber and also narrowing of the angle. So as you can imagine here, this is pre-op and post-operative appearance of the cornea and anterior chamber depth. It induces a dramatic and significant shallowing of the anterior chamber and crowding of the angle. Also, large grafts and thick peripheral cornea can induce more crowding and distortion of the angle. So if this is the graft, which is large enough to cause crowding of the angle and peripheral corneal thickening, also can, I'm sorry, this can cause collapsing of the Schlemm canal and redundant decimus membrane. So in general, any shallowing of the anterior chamber, either by suturing or whatever, can be exacerbated if there is a corneal perforation or wound dehiscence. So shallowing of the anterior chamber can cause, in a long term, can cause peripheral anterior synechia. So the longer the duration or the longer the period between the perforation and the transplant, perforation and the transplant, the higher the risk of glaucoma. This is one of my cases that refer to me because of the high intraocular pressure. This is 16-year-old who's known to have a keratoconus secondary to vacancy, and he did penetrating keratoplasty somewhere else outside the kingdom, and he presented to us with a leakage through this area, superior nasally. It is managed at the beginning by gluing, but actually the perforation is still there and the leaky area it didn't improve with gluing. So hypotony on long-standing hypotony and shallowing of the anterior chamber for months induce, unfortunately, permanent angle closure. This is the picture by OCT. As you can see, the angle is totally closed and the pressure at the time of presentation was too high. So we managed to control this problem medically, fortunately, and he's stable afterwards. Again, one of the later causes of glaucoma after penetrating keratoplasty is the long-term use of corticosteroids. So many theories that can, postulated for the distortion of the angle. This is reported by Olson and Kaufman. They mentioned that the excessive tissue in the angle and trabecular collapse. Zimmerman and Kroppen, they have a theory describing this issue. They thought that the conventional mid-stromal corneal sutures can produce a slight posterior wound, as we mentioned before. And any procedure that can penetrate the Descemet's membrane, you lose the anterior supports of the angle structures. And also lens extraction or aphakic patients, you may lose the posterior supports of the angle. So if you do a mid-stromal corneal wound, a mid-stromal corneal suturing in a patient who is aphakic, you may induce, angle collapse or trabecular collapse, and this is going to be causing glaucoma. So this is just a diagram can illustrate what we have said already. If this is the trabecular meshwork apparatus and the patient is already phakic, and we are sure that the posterior support is still intact, and the ciliary body is almost there and pulling back the posterior support. And anterior support, which here represented by the Descemet's membrane, is still intact. So we are sure that the trabecular meshwork and the Schlemm canal is still functioning well. But if you lose the Descemet's membrane through penetrating keratoplasty, and if you remove the lens, you will induce collapse of the angle. So this is just another illustration. If you do mid-stromal corneal suturing, you will induce a posterior gap of the back of the cornea. And this gap is inducing Descemet's retraction, which can eventually induce crowding of the angle and limit the outflow facility. On the other hand, if you do a deep enough stromal, deep enough, or maybe through and through, maybe anterior segment will not agree with me if this isn't through and through, like if it is deep enough that can keep the Descemet's membrane tight and not to retract to the angle, this may avoid any collapse of the anterior chamber angle. And this is just a short clip that can show you the ideal way of suturing the cornea. You're going deep enough to near the Descemet's membrane, and almost the same length between, in each lips of the wound, and not to tie the sutures, by the way, because if you tie the sutures, you will induce compression of the wound and shallowing of the area. Another diagram that can explain more about the posterior and anterior support. So if you do a deep enough corneal suturing, you preserve the anterior support of the angle. And this is good enough if the patient is already phakic and is not pseudophakic or aphakic. But if the patient, undergone very shallow suturing of the cornea, for sure the Descemet's membrane is going to be retracted to the angle. And on the other hand, if the patient is already aphakic and you do the same to the cornea with the mid-stromal corneal suturing, you will aggravate the problem by collapsing the angle. Another report by Gary back in the 80s supports the idea of high incidence of post-keratoplastic glaucoma. And we have to ask ourselves, is the size of the graft matters? In general, yes, if the graft is above 8.5 millimeter, it has a high risk of developing glaucoma and raise intraocular pressure as compared to other grafts with a smaller graft. And this is just because of the past formation, as you may know. And oversizing the donor cornea, it improves the outflow. But actually, it has a lot of conflicts in the literature. And but in general, oversizing the graft is associated with a deeper AC and less chance to develop peripheral anterior synechiae. I think this is not the case if the patient is having keratoconus and for refractive reason, obviously. So in general, donor button size in effective patients, and you have to use at least 0.5 millimeter larger than host bid, because this is can reduce the incidence of glaucoma. This is two old reports supporting the idea of oversizing the graft button over the refined size, host, and both of them supporting the idea, the same idea. So these are just summarizing the risk factors of penetrating keratoplasty or post-keratoplastic glaucoma, either intraoperatively or early postoperative, and this is the late postoperative period. So again, we have to ask ourselves why glaucoma is associated with Peaky failure. This report or this article summarized this. It's by Price and his colleagues. They mentioned that there is a risk of failure from rejections, and this risk is doubled. And endothelial decompensation, the risk of the endothelial decompensation is doubled if the patient has glaucoma, and the ocular surface complication is tripled if the patient has glaucoma. So these causes or these risks can aggravate the problem. This is a multi-center cornea donor study found that the risk of PK failure was 2 times higher in eyes with medically managed glaucoma, and 3 times if the patient surgically managed. And if the patient is both medically and surgically managed, this risk is becoming higher to 7 times. And so the Peaky failure in a patient who is medically and surgically managed is very high, reaching 7 times. One theory that postulated that the corneal or aqueous concentration of the protein is higher in trabeculectomy. It may reach 5-folds, and it may reach also 10-folds if the patient undergone glaucoma drainage devices. So this protein concentration in the aqueous may play a role in the graft failure. Another rule of failure is because of the Peaky is cut. You're cutting the corneal nerves and producing anesthetic cornea, and also this requires long-standing suturing. So these effects or these factors can, play a role in the failure rate. Also, in glaucoma patients, most of these medications can cause dryness, and also these preservatives can aggravate the problem. So these can increase the ocular surface disease and inflammation, and eventually the graft rejection. So let's move to the LKB, or glaucoma after deep anterior lamellar keratoplasty. As you know, in these procedures, we preserve the descendant membrane, and this technique is preserving the descendant membrane, and also preserving the angle from damaging. And this report, approved this idea because it decreased with anterior lamellar keratoplasty and endothelial keratoplasty, when we compare this to the penetrating keratoplasty. So they believe that this is due decreased surgery-induced damage to the anterior chamber angle. They mentioned on the same article that if the patient has a pre-existing glaucoma, this may aggravate the problem. And if it is penetrating keratoplasty, again, this is make the problem worse. And if the patient underwent combined anterior segment procedure like IOL removal or exchange, this may also adding problems to the situation. And if the patient is aphakic already, again, this is another problem. So this is an interesting case published in 2017. He is 25-year-old who was having bilateral keratoconus, underwent uneventful deep lamellar keratoplasty as described by the surgeon with using big bubble technique. So during the surgery, air was injected in a deep groove and 70% of stromal thickness using 27 gauge needle, air bubble injected and allowing for the dissection of the recipient cornea. And the stromal was carefully removed and the donor cornea graft secured successfully by sutures. On the postoperative day one, the patient experienced very painful eye and headache with nausea. And the vision shockingly was hand motion. And the pressure was too high. So this is the photo of the eye, as you can see. And if you examine the patient, you can see the ciliary flush with hazy graft and edematous cornea. The pupil was mid-dilated and poor reactive to light. And the AC was deep centrally, but very shallow peripherally. And the iris appears to be on a concave configuration. And fortunately, the reflex was normal. So they decided to go and do OCT for the anterior segment. So they found this like membrane, occupying the pupillary area. They don't know what is it, but after examining the patient, and they found that this is just an extension of a layer of Descemet's membrane involving the anterior surface of the iris. And this is just residual stroma. So the surgeon didn't reach the Descemet's though. And what we left in between is the air bubble. So the story become clear for them, and this is maybe related to poor technique and the bubble, trapped between the Descemet's and the residual stroma. So the patient brought back to the OR actually promptly, and they remove the cornea and the graft, and they continue dissecting the residual stroma, and they evacuate the air bubble from there. And luckily, the Descemet's membrane is still intact, and they put back the graft and suturing in place as well. So the patient after 1 year was doing good. The pressure was 13 and the vision was 20/80, and he was comfortable without any glaucoma medications. So be mindful of this, because sometimes you're not reaching actually the Descemet's membrane and you're injecting bubble on a wrong place. All right, so let's move on to glaucoma after endothelial keratoplasty. So the beauty of endothelial keratoplasty, it has a small incision and it maintains the corneal sensation, and it requires a little sutures. So, but the prior glaucoma surgery is the single biggest risk factors of failure of these procedures. So glaucoma after endothelial keratoplasty has been reported to occur up to 15% of cases. And in this very good study by Ansho and his associates, they found that the survival rate of 5 years graft is 94% in eyes without any previous glaucoma. And if the patient is medically managed, it reaches 90%. And if the patient undergone trabeculectomy before, this come down to 59%. And the survival rate of these grafts drop down to 25% if the patient has a prior glaucoma drainage devices. So they maybe think about two mechanisms, either pupillary block related to the air bubble, or the trabecular meshwork obstruction related to long-term use of steroids. This is, I mean, an article explained this. So as even if you do a PI in these cases, it's going to be blocked by the air bubble. And this air bubble pushing the lens on the other side to block another peripheral iridotomy created on the other side. So the actual management or the ideal management is just to start medically and to release these bubbles or these air through the paracentesis. So again, for sake of time, let's move to the keratoprothesis associated with the glaucoma. Usually, this is, I mean, a big subject. We have to cover it I mean, a separate lecture, but we have to include it here. These procedures, it's been revolutionary for the last 2 decades. Actually, it has a front part, which is the optical parts made up of PMMA, and the back plates, sometimes made of titanium, and the locking ring, which makes the complex secured and put these, I mean, parts or elements all together, and the cadaveric cornea in between. So these procedures is not without complications. So either extrusion of the implants or necrosis of the cornea or endophthalmitis or glaucoma that can happen frequently. So always the management of glaucoma is challenging. So this is just because it has a rapid progression and you are unable to measure the IOP inaccurately, and no standard guidelines actually for glaucoma surveillance and monitoring after keratoprosthesis surgeries. 36 to 76% of pre-existing glaucoma of patients receiving K-pros, and many had undergone prior glaucoma surgeries. These, the underlying causes of keratoprosthesis procedures, uh, corneal decompensations and herpes simplex viruses, Steven-Johnson's, chemical burns, or prior failed penetrating keratoplasties. So the incidence of glaucoma following K-pro surgeries, it has usually an aggressive course, and the postoperative period from 14 to 28% have elevated intraocular pressure, and 7 to 14% progresses with time, and the progression is 0.075 per year if the patient has glaucoma afterwards. So what's the etiology behind this? Those patients has pre-existing glaucoma most of the time, or anterior segment damage, either by inflammation or trauma, and they may develop retroprosthetic membrane or pus formation, and distortion of the angle or collapse of the trabecular meshwork after removal of the iris, and inflammation and vitreous prolapse can play a role of obstruction of the trabecular meshwork. And sometimes inflammation postoperatively can release cytokines and apoptosis of retinal ganglion cells. So always anterior segment OCT is helpful to detect any abnormalities or shallowing or angle closure in these cases. So don't hesitate to order anterior segment OCT in those patients just to detect any progression of angle closure or shallowing or any problem that can happen during the course of the management. So as you can see here, the angle is open on the other side while it is completely closed on the other side. And this is the patient who has failed graft, multiple grafts failed, and he underwent keratoprosthesis. So at the beginning, he has nicely, beautifully open angle, and is still the same 3 months post-operatively after K-pros, and the angle start to be blocked, and the peripheral anterior synechiae start to form, and at the end of the 1 year, completely angle closure in all directions. So this can be picked up during examination of the anterior segmental CT. And this is another case where we can detect the tube, which is combined with the capros, and this is the cross section of the tube, and this is like a longitudinal section of the tube that can be obvious here. You can see it here. And as we all mentioning that the anterior segment OCT is helpful to detect these findings. So one of the challenges is these patients didn't improve or didn't respond to glaucoma medications. That was because the ocular surface area is decreased, and most of the ocular surface is occupied by these prostheses. So the uptake or the absorption of this medication is less than usual. And also the long-term use of steroids has another role of developing glaucoma. So usually it's uneventful, beautifully done, and no complications. But sometimes it can develop complications, like in this patient where the vitreous is blocking the tube, and it was simply treated by doing YAG laser just to release the vitreous from the tip and from the lumen of the tube. And also the tube can be stuck with the remnant capsule of the IOL. So the capsule just again simply removed and lysed with the YAG capsulotomy and the YAG laser. Again, the iris tissue can block the tip of the tube, and we use the laser to make the tube tip free of iris tissue. Another challenge of these cases is difficulty in measuring the IOP, and the handheld tonometer usually is the acceptable method to measure the IOP, but it's not and in the center of the cornea. It's usually at the limbus, and it's maybe an alternative to other modality. And if you use a pneumotonometer, you can put it at the limbus or on the sclera. Make sure that it is away from the plate or away from the area of the prosthesis. And you have to keep in mind, and this is going to be overestimated by at least 9 or 10 millimeter mercury. And if you have the other eye is within normal, you can compare this to the other eye. Still, the finger tension or the tactile, finger palpation is useful in these, procedures just to detect the intraocular pressure. If the pressure is above 30, because it's less useful, it is if the pressure is below 30. And as we mentioned, scleral pneumotonometer is another, alternative here. And transpalpebral or diaton is one of the modality which is not usually available in all healthcare centers, but it is one of the options. And changes in this is in general, which is applied for all the keratoplasties, that the changes in corneal thickness and astigmatism and the refractive changes, these make the management or the measurement of the intraocular pressure more challenging. So maybe you can use these modalities, either pneumotonometer or tonopen, or maybe dynamic contour tonometer, which is usually independent of the corneal thickness or surface irregularities. Uh, but the most accurate thing is the Goldman applanation tonometer, provided the surface of the cornea or the graft is smooth enough to reflect the Myers. And the eye care becoming a more public, or in the near future, because it's comparable to applanation Goldman tonometer, and it is one of the alternative if the anterior surface of the graft is not smooth enough to go for applanation. As we mentioned before, that the finger tension or palpation is commonly used in case of keratoprosthesis, or you cannot do any instrumentation here. But as I mentioned before, that if the pressure above 30, this is can be reliable. Otherwise, it's going to be, I mean, different between practitioners. So this paper supports the thing that the finger tension or palpation is, a good method for IOP estimation, and it remains useful for detecting intraocular pressure. So let's move to the management of glaucoma after these keratoplasty. We have to keep in mind these preventive measures, that the donor graft should be larger than the recipient grafts, and the sutures should be looser and shorter, and smaller to fine size, and the corneal peripheral area should be thinner, and the larger overall corneal diameter should be performed, and the sutures should be deep enough, and the suture bias should be equal on both lips of the wound. So moving to the medical management, we'll start usually by beta blockers, and we have to keep in mind these side effects. Alpha agonists like brimonidine and apraclidine is effective here, and myotics like pilocarpine is usually avoided because of the side effects like uveitis or RD. And carbonic anhydrase inhibitors is one of the options, but try to avoid them at the early postoperative period because this can induce corneal decompensation and graft rejection afterwards. And this is a very nice paper that supports this idea that the dorzolamide per se can cause irreversible corneal edema if you use it in the early postoperative period. Carbonic anhydrase in a systemic like acetazolamide is, useful in early post-operative period for shorter period of time, but again, be cautious of the adverse events. Prostaglandins usually avoided because of these side effects, and we can use it if the patient is quiet enough, and there is no, the patient is phakic or he has no other concerns. Steroids, again, if the patient is in long-term steroid use, we can shift between steroids to go for the weaker steroids, or maybe you have to taper down the steroid to the minimum frequency. And some reports that supporting the cyclosporine use because it has an element of to control the intraocular pressure. So the surgical management, usually we go for the minimum invasive, like in this procedure. This is penetration keratoplasty in patients who developed high intraocular pressure. So the surgeon decided to go for angle surgery. He decided to go for gonioscopic assisted transluminal trabeculotomy, and he used only proline, 50 proline here, and he catheterized, or sorry, he just burned the tip just to facilitate the passage of the tip of the suture through the hallway of the trabeculum or the Schlemm canal. Another modality of treatment is using the same procedure, but with eye track or microcatheter, like in this patient. He's known to have keratoconus, and he underwent deep lamellar anterior keratoplasty, and he developed steroid-induced glaucoma, and he was unresponsive to medications. So I decided to go for eye catheter, transluminal trabeculotomy ab interno, and the patient did very well after the surgery, and he stopped the glaucoma medications, and the pressure was between 13 and 15 of medications. And again, Ahmed implant has a role in surgical management of penetrating keratoplasty. And this is a patient after traumatic glaucoma, and also he underwent previously combined Peaky and IOL implantation, and he developed a glaucoma, obviously, and we managed this glaucoma with Ahmed implant. And nothing specific in Ahmed implant here, but the thing is, it's better to keep the tube as posterior as you can, and given the patient is high risk of exposure with very thin conjunctiva and has high risk of exposure. We put tube under the scleral flap, and I like to ligate this tube with 7 or 8 Vicryl just to avoid any early postoperative complications. So this patient did very well after the surgery, and the pressure after like maybe 2 months, because the, the the tube started functioning after like 2 months, and he was on medications for that period of time, and he was doing very well after the surgery. This is a report by an Indian journal. They described the placement of the tube in the sulcus in phakic patients. They're trying to avoid any contact between the tube and the grafted cornea, and they mentioning that if you put it as posterior as you can, you decrease the risk of decompensation and graft failure. So actually, I'm not comfortable to do this because this can induce cataract, as you can see. And even if the patient is younger and you urge or you are pushed to go for cataract surgery, you may lose the accommodation of the eye. So maybe this is I mean safe for them, but I'm not sure if it's safe for our patients where there is a very limited space to put the tube in there. This is another patient where he developed multiple failure of penetrating keratoplasty. Now, the decision was to go for K-Pro in addition to Ahmed valve implants, and the surgeon used here the FP8 design of the Ahmed implant. So this is the fast-forward clip just to describe it is combined between keratoprosthesis and the cataract extraction, and usually the lens has to be removed, and nothing specific, just to continue. I will forward this. And just the complex of the keratoprosthesis is sutures to the eye, and then the tube inserted in the anterior chamber, as you can see here, and the clear patch graft is to cover the tube. This is again the paper just compare the different procedures. They compare the trabeculectomy and glaucoma drainage device to cyclophotocoagulation in the management of glaucoma after penetrating keratoplasty. They concluded that there is no significant differences between these procedures, but they found that there is a high chance to develop graft failure and glaucoma failure, and sometimes visual loss and hypotony if you do cyclophotocoagulations. So to sum up now, to conclude, this is just an algorithm that can describe the management plan if you have an intraocular pressure high after penetrating keratoplasty. So usually we have to start by aquasuppressant, and if the patient is having an inflammation, we can use steroids. And if the pressure is persistently high, we can examine the angle. If the angle is open, we can look for any retained viscoelastic or hyphemia or lens particle after the surgery, and we have to rule any element of steroid response. If this is an issue, we have to treat the underlying cause, and if the angle is closed, we have to look for any pupillary block or peripheral anterior synechia. So if there is any pupillary block, for sure we have to go for YAG-BI and maybe goniosyneuchalisis, and don't forget to rule out aqueous misdirection. Again, if the pressure didn't respond to these measures, we have to go for surgical options like trabeculectomy or glaucoma drainage device. Personally, I will go for something minimally invasive if the visibility is allowing me to go for this. Otherwise, we can go for major things. The cyclodestructive procedures, I will put it at the bottom of the list given the complications and the rate of inflammation post-operative is, quite high. Thank you very much.
Thank you so much, Dr. Ali, for this very excellent presentation and very interesting illustrations and animations and videos. Actually, I can see the effort that was put to prepare this presentation. So before we receive the questions from the audiences, let me through my first question. Now, you nicely explained the theory of the anterior and posterior support, and you mentioned about the role of the lens to make the posterior support. So do you think in order just to, decrease the risk of having glaucoma in those cases that we should discuss it with our cornea colleagues, not to perform combined PKP with lens extraction at the same time, especially in patients who are already non-glaucoma or they are having the risk to develop glaucoma later? What do you think?
Yes, I'm supporting this, but sometimes the patient has cataract surgery. Has a cataract at the same of the procedure, and it's better for them to go for combined. But I agree with you. If the cataract surgery can be delayed or postponed for enough time, just to evaluate the patient after the keratoplasty and see, because doing combined surgery at the same time is not good for glaucoma management, and it's going to progress with time for sure.
Okay. My other question is regarding the glaucoma in K-Pro cases. So maybe you agree that we prefer to control the glaucoma first before the patient goes for K-Pro. So we do our tubes or cyclodestructive procedures, and then the patient later go for a K-Pro. Now, what is the time frame for those patients? I mean, how long is the period that you give them after the glaucoma surgery, then they can proceed for the K-Pro?
This is a good idea, but sometimes it's not. It's out of our hands because glaucoma procedures, especially tube procedures, is not easy to perform before K-bros. One either is difficult to localize the tube where to go for it, and if you plan to go for pars plana, you have to have a good visualization to the vitreous, which is difficult to do. Before. But if you have a chance to do it combined with the K-Pro, this is maybe the only thing we can do. Otherwise, maybe post-operative, we can do subsequent tubes or maybe CBC afterwards.
Mhm. And you know that there are some ideas nowadays of using the ultrasound, the UCP, before the K-Pro, or in a combination, in a junction with the K-Pro. What is your idea about this?
Yeah, Dr. Corrad is working on this, and we are interesting to have the results. But I have, confusion, and still, my question in my head is where to localize the probe or the cone itself. It's difficult to see the cornea itself, and also, if any decentration of the cone is going to be an issue for the angle itself and the cornea itself, and but I'm interested to see the results of these cases.
So if UCP is elected, then maybe we have to do it before the K-Pro.
For sure, it's
Yep.
but it's difficult where the anterior segment or the anterior
Yes.
surface is completely conjunctivalized and scarred, and it's difficult to localize where is the limbus. So, which is essential and crucial to localize it to apply the probe just to have a good results.
Yeah. You showed the case of GATT procedure. So do you think the other MIGs like iStent, Kahoot would have a role in those cases?
I think GAT or whatever the mixed procedures, if it is doing great in some cases, like an open angle, it's going to be a very good result if you do it in an open angle secondary to either steroid response or post-keratoplasty. So the principle is the same. But I found that the GAT procedure, where you rip off the trabecular membrane or trabecular meshwork 360, this is give an additional result over the other modality of management in terms of either stent or maybe Cahock.
Okay. Okay. Now let's open the floor for the audiences to ask. I will start with Dr. Omar Kirat. Dr. Kirat, can you unmute yourself, please? And
Assalamu alaikum wa rahmatullahi wa barakatuh.
salam.
Thank you, Dr. Ali, very much for this excellent lecture. It's always something we share with the glaucoma in caring for patients with cornea and glaucoma disease. One comment regarding your recommendation to use loose sutures. It's a good advice, but I want to draw the attention of the fellows of the anterior segment not to make it so loose, because your term is, of course, a relative term. As regarding aligning the or the depth of the suture, yes, usually in BKB it's nearly 90% in the donor and in the recipient, and in lamellar we tend to push the graft posteriorly by taking a relatively shallow bite in the lamellar and yet deep bite in the recipient. The use of Diamox and the paper that stated that it may affect the endothelial cell function. Some papers are misleading, and if, for example, I come across a case that never cleared after BKB or endothelial kerat transplantation, in which I used Diamox, I will never blame the Diamox, but I will blame the quality of the graft. We commonly use Diamox in nearly all the full thickness grafts to avoid the elevation of the intraocular pressure postoperatively, which can result in dire consequences like uricophalia. Right. So Diamox, I will not hesitate to use it after keratoplasty. The one important thing is to pay very close attention to PAS, peripheral anterior synechia. Any degree of PAS, if can be released, should be released. And some cases of trivial iridocorneal adhesions, if left, can result in propagation and then complete loss of the angle. And it's not only the glaucoma, but if the iris gets adherent to the back of the cornea, then subsequent keratoplasties usually fail. The other point is the cyclodestructive procedure versus drainage procedures. I think in the anterior segment we prefer the drainage procedures, though again some papers may show no differences, but I would blame the number of cases, because the word statistically significant may again be misleading. We notice significant inflammation after the cyclodestructive procedures, and as compared to the drainage, actually the drainage device actually drains whatever inflammatory material, most of the inflammatory materials. These materials, if left in the AC, will accumulate in the angle over the structures in the AC, including the graft. Thank you very much, Dr. Ali, for this very informative lecture.
You're welcome. Thank you very much for your comments, and always your comments adding to my knowledge all the time. So just one comment regarding the sutures. Yes, agree with you, not to put it very loose to just to keep the wound leak, and not too tight just to disturb the wound. And regarding the comments about the Diamox, actually the paper is regarding the topical dorzolamide, not related to the Diamox. So you can use Diamox and no restriction of this, but the paper talking about the dorzolamide itself, the topical dorzolamide like Zola or Trozopt, these can affect the corneal endothelium and can stress the endothelial cells and affect the pumping effect of these cells, and can induce decompensation or edema. Thank you very much for your comments again.
Thank you so much, Dr. Ali. Thank you, Dr. Umar. And I do agree with that you prefer doing a tube rather than cyclodestructive procedure. But nowadays, with the new development of the cyclodestructive procedures, having the micropulse, risk of inflammation that we see is much, much less than the conventional cyclophotocoagulation. Thank you again, Dr. Omar. Dr. Hernan Osorio, please go ahead.
Good afternoon. Thank you, Dr. Owaida. Congratulations, Dr. Besh. It was an excellent talk and you did an excellent review. I have two considerations regarding your question, Dr. Owaida. The first one is related to cataract surgery and Peaky. We are doing always, most of the times, the combined procedure at the same time. And the reason is because if we postpone the cataract surgery, we are jeopardize the endothelium. This is the main reason why we are doing the surgery at the same time. And is the complication and also the glaucoma is related with the surgeon experience. If the surgery was complicated, maybe PCR, or maybe the patient, finally the surgeon left a lot of cortical material, this patient is prone to develop glaucoma. When you are doing this kind of combined procedure, you need experience first, and you need to do a careful surgery. And also, when you are talking also about the new surgeries and like the UCP or the GAT, you have to take care in consideration also the endothelium. I saw a patient that after these new procedures, they start to, the endothelial cell numbers start to decrease really fast during the first 6 months. And I have some patient with that I am requesting the endothelial cell count, and I have I have the numbers of this decrease of the endothelial cells so fast in the first 6 months. So we have to take care when we start to do this new procedure in this patient with PKP, because normally the patient in the first year after any corneal procedure, most of them lost 30% of the original endothelial cell count. And after that, there is stabilization in the loss of the endothelial cell count. The other consideration is regarding the keratoplasties. Now we are using a phakic keratoplasties. When you are using a phakic keratoplasties, we are removing the iris, the lens, we are doing anterior vitrectomy. Then we are destroying at the same time the trabeculous meshwork. We know now that 100% of the patients that we are undergoing keratoplasties, finally they finish in glaucoma, 100%, all of them, no exceptions. Is because the patient has pre-existing glaucoma or the patient has de novo glaucoma, but 100% of the finishing glaucoma. And right now, the recommendation is the patient have glaucoma diagnosed before the patient have to do a surgery, a combined surgery, before or at the same time of the surgery. It depends on the visualization of the anterior chamber, it depends on the keratoplasties we're gonna use. And if the patient before the surgery doesn't have glaucoma, we have to start immediately to go. So this is the recommendation, the worldwide recommendation right now. Keratoplasties is so difficult to deal with them, the glaucoma or the other complication, the retinal detachment, the infection, all the infection related with the microbial keratitis, with endophthalmitis. But glaucoma is the main concern of the keratoplasties because all of them has glaucoma. Recently, Sarah, she finished her fellowship thesis. Maybe Dr. Malik will talk about it because he raised his hand and he can explain what was the outcome of the fellowship thesis. But it was so interesting because the conclusion of this thesis was that if we are doing the glaucoma surgery before the keratoplasties, we have less complication of the ocular surface. Because most of the time the rubbing, the eyelid and the rubbing of the contact lens, finally the patient finishes in conjunctival erosion over the tube. And this is a big complication because the patient can develop the endophthalmitis later on. So there are several considerations regarding keratoplasties, but the most important thing is we need a multidisciplinary team. We need to work as a team. We need to talk between the specialists before we're gonna undergo any surgery. For example, right now, every time I will book one patient for keratoplasties insertion, I always talk with the glaucoma specialist and especially before the surgery and arrange the surgery. If the patient need maybe the combined procedure, or maybe we wanna do we're going to delay some of the surgeries. This is so important to work in a multidisciplinary team. And finally, the other consideration, I don't know if Dr. Kira, this is still around, is regarding the steroid-induced glaucoma. I review all the patients. I did lamellar keratoplasty during the last 5 years. I've been working in the hospital, and also I was talking with Dr. Kirat, another cornea specialist in the hospital, and more or less 15% of our patients are steroid-induced after a straightforward LKP, lamellar keratoplasty, and 50% was not reported worldwide in any place. This is so high incidence of steroid-induced glaucoma after LKP, 15%. And I have patients with 22, 24 years old blind because the patient disappeared 6, 9 months, and after the patient came using Predforte, used 6 hours, and finally the patient arrived with the advanced glaucoma, finally blind. So in the hospital, we had to take care about the patient with LKP that more or less around 15% of them finally develop steroid-induced glaucoma. This is so important to take in consideration also.
Thank you so much, Dr. Thank you so much, Dr. Osorio, and thanks for mentioning that tip about the placement of the tube of Ahmed implant in cases of K-Pro. This is a very important point, especially for our fellows when they place those tubes. They should go as far as posterior as they can, because they should consider the placement of the contact lens that you need to put after the K-Pro. Now, before I go for the last question from Dr. Rizwan Malik, if he's still with us, I would like to give just quick announcement. We still have the Retina OCT course at 3 o'clock by Dr. Sausan Niwelati. She's going to give the course at 3:15. Okay? So she wants to give everyone the chance to pray and relax. And 3:15, you can join Dr. Niwelati. Our last question by Dr. Rizwan Malik. Dr. Malik, are you there?
Yes, I'm here.
Yes, please, go ahead.
Just a comment, really. Dr. Bishri mentioned in his very nice talk about Tygonia aniculitis briefly. And I've really been surprised the number of times and a handful of cases this has worked. So, gonius aniculitis, just dividing the PAS in these patients with secondary angle closure, especially if they're of recent onset in the last few months, can be very effective and can avoid the need for a tube later on. And it seems to work better in those eyes where the graft is not too tight and there's more space in the potential space in the anterior chamber angle, so that once you divide the adhesions, then the anatomy is restored and it stays like that. But in the cases where the graft is more tight, then it's less likely to work. And I noticed that you have to keep the patients on very heavy steroids because the PAS reform very quickly. So if you do that procedure, but you have to keep them on intensive topical steroid afterwards for a while. But it certainly worked in 2 or 3 patients who had like pressure of 30, 40, and a year later they had normal pressure without any drops. So it's worth always thinking about this, especially if it's a recent onset of glaucoma.
Thank you so much, Dr. Malik. Dr. Bishri, would you like to comment?
Yeah, I agree with him that the synechia, if it is within the 6 months of the procedure, we can do it because the angle itself is still, has a potential functioning. But if it is like 1 year and above, I don't think that the angle or the trabecular meshwork and apparatus is going to, refunctioning again, unless you combine the synechia with any angle surgery, either just to canalize the Schlemm canal or do something for, enlarging or ripping off the trabecular meshwork. But I agree with the heavy steroid use after the surgery because reformation of the PAS is frequently happening.
Thank you so much, Dr. Rizwan Malik, and thank you, Dr. Ali Bishri, again for this excellent presentation. And just for the sake of the time, I think we have to stop here. I would like to thank you all the audiences. Please stay safe. Please register and go for the COVID vaccine as soon as possible. I wish you have a very pleasant time and enjoy the weather. And thank you so much. Take care. Goodbye.